So now we're going to move on to a pre-recorded interview that we've got with Dr. Zoe Winters, who is a senior consultant breast cancer surgeon. And in this interview, pre-recorded especially for International Women's Day on BCFM, Christina Rubino interviews Zoe about her work around breast cancer.
Hi, well, it's International Women's Day, and this is Christina Rubino, and I'm out and about, and actually I've tracked down one of our, I believe, best breast surgeons in the country, and we're very lucky to have her here in Bristol, and that's Dr. Zoe Winters. Many years ago when I met Zoe, it was at dinner with the wonderful Pat Pilkington, who founded the Penny Bowen Cancer Help Centre, and Pat's dream was always that there should be a really great quality of life study, because she felt that there's been an enormous amount of evidence around, but a lack of evidence on the best outcomes when facing breast surgery. And Dr. Zoe Winters is a breast surgeon. Now, when we hear about cancer in the media, we hear about cancer at the point of diagnosis. We're overwhelmed with information about how much broccoli we should eat and how many vegetables we should have every day. And from the perspective of the patient, there's often a feeling of, am I getting the right quality of life? Am I getting it right? So I'm going to hand over to Zoe Winters now and let her talk a little bit about her role as a breast surgeon and how breast surgery is often something from the perspective of the patient that isn't really talked about an awful lot. Let's hear a little bit about surgery and about quality of life. Zoe.
Thank you very much, Christina. I think the first thing to say is that there's been massive progress over the last decade, and I think the things that I'm finding most exciting is not the questions that we had 10 or 20 years ago when surgeons regarded maximization of surgery as the way forward. Most of the advances that are so exciting for surgeons have come across because we are advancing what we call personalized medicine. This is about understanding what type of breast cancer you have that we can use as targets in a personalized signature. And so we're almost moving towards strategies that encompass what we call minimization of surgery. And this is also extended to the armpit.
That's great, and I just wanted to sort of make clear that having a breast surgeon who is really, really approachable and talks about personalised care is vital. How important is that, do you think, for a surgeon, to actually match what you're saying to the person who sat in front of you without being patronising and letting them know that they're in safe hands?
I think it's about making sure that surgeons and healthcare providers are giving the breadth of information and choice and options. And that can be sometimes quite cumbersome for women when at the time of diagnosis they have huge levels of anxiety. And I would say that a really good surgeon always presents options that are evidence-based. And what do I mean by that? Evidence-based doesn't mean I've done 5 cases of this and it works well. It means going back, does that surgeon present the information that comes out of the highest quality studies that tell us the most and inform us the best? The question of giving personalized medicine is simply saying that it's going back to the grassroots facts, making sure that when I give a diagnosis to women, that I have the pathology report in front of us, I have the radiology reports in front of us, and that I take that woman and her family through every fact. It's about making that woman part of the decision-making process. It's called shared decision-making. Ultimately, we can give choices which are as good as the other, and that then sometimes results in patient-centered treatment where women will say, well, I think I will have my chemotherapy first to shrink down a tumor so that we can save your breast. Or other women may say, I would prefer a mastectomy and reconstruction. And then, of course, that extends out into all of those choices. What is suitable for an immediate reconstruction can depend on the other cancer-related treatments like chemotherapy or radiotherapy. So it is sometimes quite a complex discussion. And so we need to iterate that more than once. And I'm very fortunate to work at the Bristol Breast Care Centre in Southmead, where we have a superb team of clinical nurse specialists. And so it often means that women have a number of consultations. So that decision making is not knee-jerk, it's not reactionary, it's considered, it's timely, and it's populated by evidence-based facts.
If it takes a few weeks and all the options are lined up and the patient who is at the centre of this feels in control, wouldn't that lead to a stronger patient and being more fit to fight?
You've taken the words out of my mouth, because so often, I have the breast care nurse sitting with me or other clinical nurses, and I say to the patient, you are going to become a partner in this treatment process. That means, I sort of joke with them and I say, well, look, I'm not going to give you a test on this, but you are going to have homework. And your homework is going to be to read all the information leaflets, generate your questions, bed in with the information, treat your surgeons and your breast care nurses like friends. Talk to them. You are the client. You demand the information. We are here to serve you. And I say this to women: do not believe everything your clinician says. Question it. Ask why. Ask about the options. Sometimes we encourage second opinions. That's fine. We don't always match or suit every patient. But ultimately, what we're all trying to do is be fantastic communicators. Now, that is something we weren't taught at medical school, and we've had to kind of evolve over the years.
It is incredible how far it's come, isn't it? And I hope that it gets better. Now let's talk a little bit about the quality of life and what that means.
What I would say is this. When we talk about outcomes, most doctors are not thinking about outcomes in terms of the patient self-reported measure. They are talking about outcomes they measure in the clinic. They look at your breast, they say it's red, they say there's no complications, they measure your blood pressure, they measure your breast size, etc. That's what we call a clinical outcome. It is doctor generated. What we mean by quality of life are all aspects, of your life which doctors know nothing about. And therefore, how this field evolved was smart clinicians started realizing if we were going to say that a particular intervention, a particular type of surgery, let's say it could be breast reconstruction at the time of mastectomy, which is now really occurring in about, I would say, 35% of women undergoing mastectomy. Perhaps more than that. I certainly think that most surgeons are offering reconstruction surgery at the time of cancer surgery. So if we think about that, we will never really know how effective that procedure is if we only generate doctor outcomes. So smart people, and this has now been accepted by the FDA in the USA, by NICE in the UK, coined the phrase health-related quality of life. And basically how we started developing quality of life measures was to interview patients, to talk to patients, to do big reviews of the literature and generate massive lists of issues that could happen after reconstruction, for example, or after mastectomy. And we then formulated what we call a scientific patient-reported outcome. So it basically was a questionnaire that was built up of little modules that covered how you felt in terms of your social functioning, how you functioned on a day-to-day basis, your body image, your sexual functioning, how you function physically, and emotionally, incredibly important. Now, these were not ever aspects that doctors have measured. And because quality of life has absolutely mushroomed over the last 20 years, there is now not a clinical trial in the UK that doesn't incorporate quality of life questionnaires into the assessment of how effective a surgery or a cancer treatment is.
Thank you so much, Zoe, and it was really good to end on that. It's informative and it's encouraging to know that at last quality of life, our emotional content, our psychosocial needs, our family needs are all being taken into consideration. So we're going to sign off now, Dr. Zoe Winters and Christina Rubino, and wish all the women across the world a really good day.